with the International Association of Palliative Care on universal access to palliative care, essential and broadened packages of palliative care for children and adults. My name is Silvana Luciani. I head the Non-Communicable Disease Department here at PAHO in Washington, D.C. I'm here with my colleagues and also from the International Association of Palliative Care. Our session today will be in English, Spanish, and Portuguese, so we'll have simultaneous interpreting. You just have to choose the language uh, by clicking on the button that says translation, and the session will be very interactive. We want to listen from you, so we invite you to put your name, your affiliation on the chat, put your questions or comments in the Q&A section on the screen. And I think we'll have a very good session today, and we're very excited about this webinar after the consensus process for Latin America directed by the International Association of Palliative Care about the essential package of palliative care, initially launched by the Lancet Commission and the package of the WHO for children, which describes very well drugs, human resources, and essential inputs for palliative care. So today in the webinar, we're going to present the essential and broadened package for adults and children and all the resources we have available at PAHO and the International Association on Palliative Care to strengthen palliative care. And to get started, we have some welcome words from our director, Dr. Ansel Hennis, who directs the non-communicable disease department and also in mental health, but he had an engagement. So he sent his welcome words just to say thank you very much to the International Association on Palliative Care for their collaboration, their leadership, and for sharing with us at PAHO all the work done to integrate palliative care inside the strengthening of health care services, and to make sure that in Latin America and the Caribbean, all people, no matter their age, have access to palliative care with quality and universal coverage. So Dr. Hennis sends his welcome words and thanks to the International Association of Palliative Care. To start the session today, we're going to start with a presentation, the first lecture on palliative care in strengthening healthcare systems. I invite Dr. Absent Badelia. He's professor at Purdue University and a member at the International Association on Palliative Care. Dr. Badelia, you have the floor.
Delighted to be here, to have an opportunity to share a bit of work that has been ongoing for some time, and a collaboration that has been only growing over the years between IHPC and PAHO. Are you able to see my slides okay?
Yes.
Perfect, excellent. So as Silvana mentioned, I will be discussing a bit about the opportunity to integrate palliative care into health systems and how the integration of palliative care is synergistic with the goals of system strengthening. So we are at a crossroads at the heels of a pandemic, 4 years shy of the 2030 target of achieving universal health coverage worldwide. There have been achievements to date, largely with a focus on progressive universalism, so the expansion of the types of services, the interventions that are covered across different population groups, and the proportion of costs that are covered to minimize financial hardship for populations worldwide. However, a key focus that has remained neglected and is a cornerstone of the UHC agenda is palliative care. And so when we think about minimizing coverage gaps, one has to pause to consider that progress UHC will be stymied unless we take a moment to and intentionally examine what the opportunities are for coverage of care across the full continuum of care and across the life course. Palliative care is, as I mentioned, a core component of the UHC agenda, yet it is limited in health systems performance assessment. One of the key indicators that is used to track progress on UHC, the UHC index, does include a particular indicator related to availability of oral morphine in facilities at all levels. However, this is only a starting point to effectively assess the progress on palliative care and, in turn, progress towards achieving universal health coverage. Let me begin and to frame our conversation today by sharing a definition, a consensus-based definition of palliative care that is utilized throughout this presentation and what will follow, particularly with my colleague, Dr. Tanya Pastrana. But palliative care is the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. And its key aims are to improve the quality of life of patients, their families, and their caregivers. Importantly, palliative care is critical from the point of diagnosis and as a part of comprehensive care without limiting access to treatment or curative care and through the end of life and bereavement care. This comprehensive definition is intended to address the full spectrum of services and goals of palliative care, as well as its values. Serious health-related suffering was introduced as a concept by the Lancet Commission on Global Access to Palliative Care and Pain Relief in 2018. And it is defined as suffering that is health-related when it is associated with illness or injury of any kind. And it is suffering that is serious when it cannot be relieved without medical intervention. And it comprises of various dimensions of distress, such as physical, social, spiritual, and emotional. And it is this definition that has been critical to making this shift towards ensuring that palliative care is a part of health systems performance assessment. The Lancet Commission was a group of interdisciplinary experts that were brought together to generate evidence on palliative care to address some of the gaps, eventually addressing the coverage gaps when we think about universal health coverage and achievement of UHC. And this discussion is particularly important as we are soon to mark Universal Health Coverage Day a few days from now. I want to share a bit about this journey of the Lancet Commission because it has brought to fruition many dimensions or areas of evidence that hopefully can serve as important tools to guide health systems decision-making in the Americas as well as worldwide. So the commission brought together 33 commissioners and chair, Dr. Felicia Knoll, and the late Dr. Paul Farmer, co-chair, as well as 60 co-authors representing over 25 countries. And the aim of the Lancet Commission was simple. How do we ensure that this gross injustice, this neglect of the fundamental goal of health systems, alleviation of palliative care, or should be the goal, and I'll come back to that, is appropriately tracked. And so the concept and the indicator of serious health-related suffering was developed to measure palliative care need. It is a starting point because the evidence on what the problem is can help us then generate appropriate responses. The indicator of SHS has been used to measure the global burden of SHS or palliative care need worldwide, examining in its initial phase by income group, and then later, as I'll share, some data by sex and age and other considerations. The other mandate of the commission was to develop an essential package of palliative care services and to cost that essential package alongside measuring the availability and distribution of essential opioid analgesics through the indicator of distributed opioids in morphine equivalents, or DOE, and then to develop health systems strategies that seek to expand access to palliative care through a balanced approach, which is the adequate attention to both the medical needs of all patients and the management of risk of non-medical use. The commission published its report in 2018, and since then, there has been the launch of a research hub based at the University of California, Los Angeles, UCLA, in collaboration with the IHPC and scholars from over 15 institutions worldwide. This network has sought to build on the evidence of the generated from the commission. Researchers focused on, with expertise, broad expertise, clinical, health systems, health economics, anthropology, wide range of experience and knowledge, with the common aim of training, evidence generation, dissemination, policy translation, and looking at practice implications to achieve universal palliative care. So the follow-up research is based on the recommendations of the Lancet Commission, and the work of the Hub examines palliative care at national, regional, and global levels, generating updates on SHS and DOME. And with that, I want to share some of the data, which is really setting up the appropriate evidence that can guide action by governments at the national level, subnational level. The burden of serious health-related suffering, examined and published recently through a time series analysis from 1990 to 2021, has shown that globally in 1990, 42 million individuals experienced serious health-related suffering. About 2.3 million individuals were from the Latin American and Caribbean region. I want to note that the measurement of serious health-related suffering is based on 21 conditions that were identified to most require palliative care or generate the most need for palliative care. And it assesses the number of individuals who die with the need, with experiencing SHS or decedents, so individuals who die in the year of analysis, or non-decedents, individuals who do not die in the year of analysis. And the quantification of the burden of SHS is based on 15 symptoms, 11 physical, and 4 psychological. And I will address some of the other aspects of palliative care and future considerations that seek to go beyond this. But this was an initial attempt to measure the need for palliative care. And the initial, as I mentioned, so 1990, we have 42 million individuals. This includes decedents and non-decedents. In 2021, the global figure has risen to 73.5 million individuals. And the proportion in Latin America and the Caribbean region is 4.5 million individuals. The assessment with the updated analysis from the Lancet Commission has been by sex and 4 age groups, 0 to 19 years, 20 to 49, 50 to 69, and over 70 years. Some important points and trends. 80% of this burden, whether it be 1990 or 2021, is in low and middle income countries. Globally, we've seen a 74% increase in the burden of SHS between 1990 and 2021. And that burden is increased twofold in the Latin America and Caribbean region. There's been a 35% increase in decedents, so individuals who die in the year of analysis, and a double the number of non-decedents, individuals who do not die in the year of analysis. The burden of burden of SHS associated with NCDs has dramatically increased from 1990 to 2021. And the leading causes are cancers, and consistently so across the board with only slight variation, as you can see with those two graphs, which are frameworks of our analysis. So the broader, the overarching figure to the left, the number to the left in terms of the burden, then by non-decedents and decedents, looking at male, female, different age groups, and then country income groups. And then at the end, by the different conditions, the 21 conditions. And so the leading causes across the board and over time have generally been cancers, HIV, AIDS, cerebrovascular disease, dementia, endocrine, metabolic, blood, and immune disorders, with a slight variation that in 1990, injury, poisoning, and external causes were among the top 5, shifting further down in 2021. This provides a basis for us to think about the burden of SHS, of how do you address, what are health systems interventions that can provide an opportunity to alleviate needless suffering and avoidable suffering that can be addressed with adequate access to palliative care. So the Lancet Commission used the model developed by Disease Control Priorities Project, DCP3, which has modeled essential universal health coverage, EUHC interventions to guide as a starting point for countries to do priority setting. It is intended to be an evidence-based selection of health services that are of best value and can generate the greatest impact. Large focus has relied in previous efforts and other metrics on addressing or reducing mortality and financial risk protection. But DCP3 was very intentioned in its focus on cross-cutting issues such as palliative care. And DCP3 defined packages as interventions that are conceptually related. So by health issue, target population, method of delivery. And palliative care served as a cross-cutting issue that was considered both an ethical and humanitarian imperative. And DCP3 defined essential packages as comprising interventions that are cost-effective, implementable, and that address the substantial disease burden, and for that reason, can be reasonably publicly financed as a part of the early pathway to universal health coverage. The DCP3 effort also identified a subset of high priority packages. These are a subset of the EUHC interventions, and palliative care was considered by default as being a core component in particular aspects of the palliative care package that was developed by the Lancet Commission and put forth by the Lancet Commission as being essential, as high priority, and the core basic interventions, such as addressing pain control, that must be available through every healthcare system. Now, the responding to the burden of SHS and the considering the essential package proposed by the Lancet Commission, the primary aim is to begin with the value of preserving dignity of patients and their families through alleviation of SHS. It is to guarantee explicit set of entitlements that can be covered through palliative care services. It is to contribute to a model of developing essential UHC packages that are inclusive of palliative care, to guide policymakers in prioritizing interventions, acknowledging the constraints and trade-offs that must be made in the process of strengthening health systems. And it includes an ingredients-based approach with basic medicines, equipment, and human resources for progressive expansion to achieve universal health coverage. Dr. Pastrana will detail a bit more of those elements in the next stage of that work in the next presentation. Some of the key design considerations were that, of course, the core burden of SHS is alleviated through the essential package, that it's universally accessible irrespective of the resource level of the health system by 2030, that it is available, PC provision provides, ensures PC provision or allows for safe and effective PC provision across all levels of care and settings, but especially with primary care as a core consideration, and including different emergency contexts, whether they be public health emergencies, natural disasters, or otherwise. There was an effort to consider a package that incorporated off-patent medicines, considered innovations that are frugal in terms of selection of equipment, and competency-based human resources that can then collectively be lowest cost in a way that averts financial hardship. The package has been designed to be dedicated through poor publicly mandated funding and complemented by interventions that relieve social and spiritual suffering. Critical aspect of this, that the essential package should not be the final goal of health systems seeking to achieve UHC and effectively meet the palliative care needs of a population. So the next mandate, and I'll try to go through this in the interest of time a bit quickly and then come back to this in discussion perhaps, is that aside from developing the package, we need to know the cost of it to effectively implement it, to ensure there's appropriate fiscal space and particularly if the essential package is to be publicly financed. And so the Lancet Commission cost the package in reference countries, a low-income country, a lower middle-income country, an upper middle-income country, Rwanda, Vietnam, and Mexico, respectively. And as you can see, the package was, there was sensitivity analysis done based on this table. The leftmost column for each country is a reported price of what the core medicines, equipment, and human resources would cost. And then the lowest and highest international prices that are available for comparison. And one of the key exercises that was conducted is to look at what the cost of the EUHC, the Essential Universal Health Coverage Package, would be, that is designed by DCP3 overall. This is the full set or gamut of interventions. And the estimate that was generated is this 2.16 per capita per year, or 2 to 3% of the cost of the UHC package in low-income countries, if we were to use lowest reported prices. Health system strengthening and palliative care. These are synergistic. So alleviation of suffering is a fundamental goal of medicine, and therefore it must be a fundamental goal of health systems. And if we begin with the need to generate resilient and responsive health systems, we must focus on responding to the lived experience with suffering, to avert avoidable suffering, and to improve quality of life. Palliative care is synergistic because it strengthens existing platforms, such as surgical platforms, because pain control is a core aspect and core component of surgical interventions. It is an opportunity to enhance health equity analysis through inclusion of aspects that are valued explicitly by patients and families, and to allow us to comprehensively do health systems performance assessment that is people-centered. Now, the agenda for the Americas, the health agenda for the Americas, has been set forth through the PAHO strategic plan with a focus on strengthening health security through resilient health systems. And these systems have to be responsive to not only the needs, but the health-related values of population, of which alleviation of suffering is key. Resilient health systems are based on primary health care, and as was identified in the recent Lancet Regional Health Americas Commission, resilience is a cornerstone of primary health care, and primary health care is inadequate without palliative care. And resilient health systems are better equipped to address shocks and emergencies, whether it be addressing the increasing burden of NCDs, the climate crisis, aging populations. As we saw with the pandemic, there was a tsunami of suffering by all the people engaged in the health system, the patients that we seek to serve, the individuals, the healthcare professionals trying to achieve the goal of health systems. And if we do not pay heed to the warnings that the pandemic showed us, we will repeat the challenges that we have recently witnessed, and avoidable suffering will not be addressed. So I want to end with the example of a core area of work that is continued and builds on the recommendations of the Lancet Commission, and this is the Global Access to Palliative Care, or GAP study, which aims to increase access to palliative care and pain relief services, and is intended to keep a focus on strengthening health systems towards the achievement of UHC and SDG 3. Specifically, the initial study is focused on Latin America and has had four core areas of work. The first being a global component to expand on the work that was done by the Commission to build expanded packages for children and differentiate essential and expanded packages for children and adults, and be applied in countries worldwide. The study has cost packages, the essential and expanded for adults and children in 3 anchor countries. And this is evidence that we hope to share in a future webinar focused on Colombia, El Salvador, and Mexico. Another area of work has been the integration of palliative care into health systems in these anchor countries, and to develop competency-based training on translation of evidence to action. This work, the GAP LA study, has been a partnership of over 9 organizations anchored at the University of Edinburgh, funded by the Medical Research Council. And I hope that through the next presentation, you'll learn a little bit more about the first area of work on the global component. Thank you very much.
That was wonderful. Thank you very much, Dr. Afsan Vidalia from Purdue University and member of the International Association for Palliative Care, for providing us that health system perspective on palliative care service strengthening, reviewing the Lancet Commission that identified that for the Latin American Caribbean region, the need for palliative care has doubled since 1990. So there's about 4.5 million people, mainly living with cancer, NCDs, HIV, other diseases that need expanded access to essential services, and for identifying what those essential medicines, human resources, and equipment needs are for having that basic package for palliative care with that cost of about $2 per capita, which seems like an affordable price tag to alleviate suffering and pain in our region. So thank you very much, Dr. Bedelia. Y ahora pasamos para ver en más profundidad ¿qué consiste estos paquetes de cuidados
And now we're
paliativos
going
para
to
adultos y
go
niños?
in
¿Y
depth
cuáles son las
about these
implicaciones por su
palliative care
adopción e
packages and
implementación,
what
sobre
are the
todo en la
implications
región de
about
América
their
Latina y el Caribe?
adoption
Y
and
para la siguiente
use in Latin America
presentación,
and
quiero
the
invitar a la
Caribbean.
doctora
I'd
Tania
like to invite
Pastrana de
Dr.
la
Tania
Asociación Internacional de
Pastrana
Cuidados Paliativos.
from the International
Doctora
Association of
Pastrana.
Palliative Care.
Sí, muchas
Dr.
gracias,
Pastrana.
Silvana. Muchas
Thank
gracias
you
por la
very
autorización
much,
para invitarnos a
Silvana
los miembros de la
and
organización de este evento
Pajo,
y
for
por incluir los
organizing
cuidados
this
paliativos
event
en
and
este
for
ciclo de trabajo.
including palliative
Y
care
también muchas
in
gracias a
this
ustedes, a las
work
personas que nos
cycle. And thank you
acompañan
very much
por su
to all those
presencia
with us for
en
your
la reunión.
presence here
IHPC es un placer, un
for
honor colaborar
the
en este espacio y presentar el trabajo que hemos
IAHPC.
desarrollado
It is
junto a
an honor
múltiples
to collaborate together with
aliados,
PAHO
incluida la
and multiple
OMS,
allies, including
y al compromiso
the
de numerosos profesionales
WHO,
dedicados a los cuidados
and also
paliativos en
the
el mundo.
commitment of
Bueno, hoy tengo el
numerous
privilegio de
professionals
representar este
devoted to
amplio y diverso
palliative
grupo de
care in
personas
the
que
world.
trabajamos para
So
aliviar los
I'm
sufrimientos
representing
relacionados con la
all of
salud.
them
Estoy viendo
today.
que hay algunos problemas
I
de
see
sonido.
there are some sound problems. Is everything okay?
Ok,
We're
bueno,
okay.
esta es mi presentación.
This is my presentation.
Permítame presentarles antes
Allow me
brevemente la Asociación
to
Internacional de Hospices y
introduce
Cuidados
the
Paliativos.
International
Nosotros somos una
Association for
organización
Hospice and
global sin
Palliative
ánimo de
Care.
lucro
This is a
con
global
25 años de trabajo en temas de
organization.
cuidados
It's
paliativos y
nonprofit.
trabajamos con gobiernos,
It was
organismos
founded
y
in
profesionales
2000, and we
para
work
mejorar el
with
conocimiento y
governments,
generar
agencies, and
oportunidades de
individuals
educación,
to improve
capacitación
knowledge
y
and foster
formación en
opportunities
cuidados
in
paliativos a nivel
education,
mundial. En
research,
estas
and
fotos
training around the globe.
compartidas por
Here,
miembros,
the
ustedes pueden ver
photos
momentos de cuidados
shows
paliativos en diferentes
moments
lugares
of
del mundo
palliative
y nos
care at
recuerdan
different
por qué
places
hacemos
in
lo
the
que
world.
hacemos.
They remind us of why we
En
do
la,
what we
en la
do.
IHPC contamos con más de
Uh,
1.300 miembros en
the
255 países
association
y la
has more
visión y
than
crecimiento,
3,000
libros y
members
proyectos
in
relacionados
25
con la salud.
countries, and our vision
Que es
is a world
importante
free
recordar
from
los datos que nos dice AFSAN,
suffering related
la
to
doctora
health.
Gloria, que más de
Serious
70 millones de
health-related
personas en el
suffering,
mundo
SHS. More than
experimentan
73
sufrimiento
people
severo relacionado
in
con
the
la
world
salud
experience
y que
severe
esto según las últimas
suffering
estimaciones
related with
y esto no
health.
se
And
molesta mucho porque
according
se ve que
to
el mundo
the
está lleno de
last
personas
estimations,
reales.
we see that the world is
Como
full of
decía
real
la
people,
autora Delia,
as
las Américas hay más o menos
it has been
9.2
said.
millones de
In the
personas
Americas,
que
there are about
experimentaron sufrimientos relacionados con
9.2
la salud
million
en el
people who
2021 y
experienced
de ellas casi la
suffering
mitad,
related to
4,5
health
millones de personas
in
viven en América Latina y
2021,
en el Caribe.
and half
Sabemos
of
que
them
muchas de
live
estas
in Latin
personas
America
vivieron y
and the
murieron
Caribbean. We know
sin la
that many
posibilidad
of
de
these
aliviar
people
el
lived
sufrimiento
and died
y por
without the
eso estamos
possibility of
aquí reunidos.
alleviating their
¿No? Eso es lo que
suffering,
nos une en este evento.
and that's why we are together here.
La lista de
Um,
medicamentos
the
esenciales de
essential
PAHO
medicines
consiste
in
desde
palliative care. This
1977
is a
y se
list,
va reanudando, creemos, cada
a
año. En
WHO
el
list that
2013,
exists
desde la IHPC,
since
presentamos una
2007. It's
solicitud
renewed
que
every two
incluyera una
years.
sección específica
The
para medicamentos
association
para el alivio del dolor de
requested a
los cuidados paliativos
specific
y esta fue incorporada a
section
la sección
for
2
relieving pain
desde
and
2015
palliative
y
care.
desde
It was
entonces continúa siendo
incorporated
actualizada.
in
Esta
section
lista fue
2 in
utilizada por la Comisión
2015.
Lancet que
This
acaba de
was
describir
updated by the
la doctora
Lancet
Badelia
Commission
como base para
that
los
Dr. Bedelia
medicamentos del paquete
described as a
esencial.
base for the essential package for
Bueno,
PC.
¿qué es el paquete esencial?
Um,
La Comisión Lancet lo define como
what
los
is the
insumos
essential
necesarios para
package?
ofrecer intervenciones
These are
esenciales
the
en los cuidados
necessary
paliativos al alivio
inputs
del dolor
for the
que pueden
safe and
proporcionarse de manera
effective
masiva en
provision
atención
of
primaria
essential
a primeros niveles
intervention of
y son
palliative
diseñados para
care
ser de un costo
and
mínimo,
relieving
pero
pain, and
suficiente
is
para aliviar
designed
gran
as a
parte del
minimum
sufrimiento relacionado con
cost
la salud,
package
incluso en
that
los cuidados de
every
salud
health
más
system,
limitados.
no matter
Esto
how
me parece
limited
vital
it
saber
is,
porque
should
quería que quedara muy
guarantee
claro el
universally.
mensaje
I
de qué
wanted
es
to write it in
el paquete
Spanish
esencial.
because I wanted
Este
it
paquete
to
incluye
be very clear.
medicamentos
This
y
essential
equipamientos que
package
pueden
includes
prescribirse y administrarse con
medicines,
seguridad en
equipment, and
ambientes de
human
atención primaria,
resources.
pero además
Um,
personal con las competencias
and
adecuadas para
well,
manejarse.
Medicines and equipment have to be safe, and personnel has to be trained. There's also an essential package for pediatric population. The content is the same with some adjustments. What is an expanded package? It includes additional medications, equipment, and human resources beyond those in the essential package. It is designed to address more complex palliative care needs and is implemented as additional resources become available, particularly within the public sector and health budget. Its components should be made equitably and affordably accessible to all patients with more complex needs along the continuum of care. Within the framework of the GAP project, as was mentioned by my preceding lecturer, this is the both essential packages for children and adults, but also the expanded packages. And you can read this in detail on this article, which is an open article. To update the packages, we did an international study at multiple stages, guided by the credit guides.
Conformamos un grupo coordinador de 9 expertos en cuidados paliativos, adulto y pediátrico de Global Health, Salud Pública y por supuesto expertos de cuidados paliativos que supervisaron el proceso. Como parte pediátrica fue coordinada por la doctora Verónica Dussel, que creo que está acá, y Julia Downing. Se elaboraron encuestas para adultos y pediátricos que incluían los medicamentos, equipamientos y recursos humanos incluidos en el paquete diseñado por el Lancet, la Comisión Lancet, y cada ítem fue evaluado. Luego se realizó un pretest con 8 expertos para mirar que fuera muy claro y que fuera pertinente las preguntas, y finalmente se tradujeron al español porque se han comentado que había unos países en base, ¿no? Luego se establecieron 2 paneles Delphi, uno para adultos y uno para niños, y realizamos un muestreo estratificado proporcional para asegurar la representación de países por regiones y por grupos de ingreso del Banco Mundial. En la primera ronda hicimos una evaluación inicial y se propusieron nuevos ítems. Hubo el criterio de consenso era del 70% de acuerdo para incluir o excluir, y en la segunda ronda se revisaron esos ítems sin consenso y se confirmaron las nuevas propuestas. En esta ronda se compartieron de forma anónima los resultados de las rondas previas. En un paso acá pueden ver la distribución por región de la OMS y por ingreso en el panel de adultos para la primera y la segunda ronda. Como ven, hay participación de todas las regiones del mundo.
Participation in all regions of the world, and this is the participation of the pediatric panel, led by Julia Downing and Veronica Dussel. Here, 75 pediatricians from around the world participated. Then we had the analysis of the Delphi process results for 25 experts in adults and 18 in pediatric care, that those final results, and then the packages were adjusted according to these recommendations. Finally, we prepared a report, the publication that I showed you before, another publication that is in process for the presentation of positive results. This is a very rigorous global process that allowed to create packages with minimum standards for all countries, especially for those who have limited resources, like most countries in Latin America, which my heart is at. Here you can see the essential package by the Lancet Commission. It has no substantial changes. In red, we have the new components, and there were 2 instances that were excluded from the package because things like haloperidol were included as sufficient. And you can think that this is very well. The idea is that this personnel or staff is available to be consulted by expert teams and for primary care. Here we have the essential package for children, the pediatric package. Here we can see that the administration ways are different, and there were also some changes. Not radical, but still some changes. And so we started with an essential package with all the components that I just presented. We have the medicine, the equipment, and the human resources. And
esto se llama esencial, ¿saben?
this
Porque es que no
is
puede faltar.
called
Porque deben ser
essential and
asequibles para
extended
todas las personas
packages.
que lo necesitan
And
en
this
el
has to
lugar donde
be
lo necesitan, ¿no?
accessible for
¿Y
all
cómo se
people that
relaciona con
need
el
it and in
paquete
the place where
expandido?
they need it. And how
Bueno,
does it
el
relate to
paquete
the expanded
expandido,
package? The expanded
el
package
paquete se compone de nuevos componentes,
has new components,
de nuevos componentes adicionales
additional
sugeridos por los
components
expertos
suggested by
que se
the
suman a los
experts that
incluidos en
are
el paquete
added to
esencial.
those
Es decir,
that are
el
in the
paquete
essential
expandido
package. So the
incluye
expanded
siempre el
package
paquete esencial.
includes the essential package, always.
Un ejemplo,
An
la
example,
morfina oral de liberación inmediata
oral
directa es un
morphine
opioide,
that is
es el único opioide incluido en el paquete esencial.
liberated
Entonces,
little by
en el
little
paquete
is the
expandido,
only
según las
opioid in the
necesidades o
essential
las
package.
capacidades del
And in the
país o del
expanded
sector o
package,
de la institución,
if the
se
country or the
pueden añadir
institution or the
otros
sector
opioides,
has
por
a capacity, you
ejemplo,
can add
la morfina de
other
liberación
opioids, like, for example,
prolongada o el fentanilo
long
o la
liberation,
metadona,
morphine,
oxicodona,
fentanyl,
pueden ser
hydromorphone, methadone,
adicionales, pero
oxycodone, tramadol,
además
uh,
del
but it is
esencial, ¿no?
additional to the
Bueno, en
essential
resumen,
one.
el paquete esencial
So,
de
as a
alimentos
summary, the
incluye
essential
19
adult package
medicamentos,
includes
10 tipos
19
de equipamientos
medications,
y
10
10 profesiones
equipment items,
profesionales.
and
El
10
paquete
professions.
expandido,
And the
además de
expanded
eso,
adult
34
package
medicamentos
includes
adicionales,
34
17
medications,
tipos de
17
equipamiento y
equipment
7
items,
profesionales
and
más,
7 professions,
perfiles
7
profesionales.
additional professionals, or
Eso es sería el paquete
7 additional
esencial
professions.
pediátrico que
This is
incluye
for the
22 medicamentos,
pediatric package. The
13
essential
tipos de
one includes
equipamientos y
22
7 perfiles
medications, 13 equipment
profesionales, y
items,
el
and 7
expandido
professions. And the
añade a
expanded
estos
pediatric package
esenciales medicamentos,
includes
37 medicamentos
37
adicionales,
medications,
48
48 equipment
equipamientos y
items,
8
and 8
perfiles
professions.
profesionales adicionales. Es preocupante ver que
It
muchos de los
is
medicamentos
worrying to
esenciales
see that many
pueden
of the
faltar,
essential
estaban disponibles
medicine
como los
that
expertos
cannot be missing
enfatizaron en el
are
estudio.
not
Incluso
available according to
la
the experts that
morfina de
participated in
liberación
the study,
inmediata y la morfina inyectable,
including
que son los pilares del tratamiento del dolor severo,
injectable
no estaban
morphine
disponibles en
and
varios
immediate
contextos.
release
Y
morphine
no se imaginan,
that treat
pero
severe pain were
en
not available in
países,
different
o sea,
contexts. And there are
instituciones
countries in
que no
our region and
cuentan
our
con
institutions
morfina oral de
that
liberación
do not
inmediata.
have
Esa
oral
es una
immediate
gran
release
oportunidad para
morphine. And
avanzar
so
en
this
este
is a
aspecto, ¿no?
great
Bueno, pero no basta
opportunity.
con que los medicamentos esenciales estén disponibles. Es
And
fundamental también saber
having
usarlos
available
de forma
medicine,
adecuada,
having
en
essential medicine
especialmente
available
en el
is
primer
not
nivel de
enough.
atención.
They also need to be used well
Por eso, como
in the
parte del
primary
convenio de la
care
IHPC
level.
con la
And so, as
Organización
part
Mundial
of
de la Salud,
the
elaboramos este
convention
manual para
and
el uso de medicamentos esenciales
WHO, we
para alivio del
created this
dolor y
manual
cuidados
for the use
paliativos
of
en la
essential
atención primaria,
medicines
que
for pain relief and
finalmente
palliative care,
coincidió con el GAP.
which
La publicación de
and
este
the
manual y
publication
también
of
el
this
manual están
manual
libres de acceso, o sea, pueden entrar
are
y les invito
free,
a
are access
consultarlos, ¿no?
free, and you can
¿Qué hicimos?
consult it.
Primero
What did we
recopilamos
do?
guías
First
disponibles
of
sobre el uso
all,
de
we
medicamentos esenciales en cuidados
compiled
paliativos
the
con la
use
idea
of
de que las guías
essential
están basadas en la
medicine
evidencia y están
with the idea
validadas
that
por
the guides
pares.
are based on
A
evidence
partir
and
de estas
are
guías, un grupo de
validated by
expertos
peers. And so,
extrajo
with these
información
guides,
sobre dosis
we extract
iniciales e
information on
intervalos,
initial
dosis
doses,
máximas para cada
intervals,
medicamento.
maximum doses
Los
for
datos
each
faltantes o
medicine.
sin consenso se sometieron a un
The
proceso Delphi
missing data
global en el que
were
participaron
submitted to a
profesionales de
Delphi
múltiples
process where
regiones y niveles
we had
del mundo,
professionals
pues, de
from
la
different
Organización Mundial de la
regions
Salud y
and
diferentes niveles de ingreso, y
WHO
realizamos
and
dos
different
rondas Delphi
levels of care, and we had
con la
two
conciencia
Delphi
del
rounds
70%
with a
apoyar
70%
una
consensus
recomendación.
to know if they
Finalmente, esas
supported
recomendaciones
recommendations.
consensuadas
Finally,
fueron
these
realizadas por
recommendations
23
were
expertos
done by
adicionales en
23
cuidados
additional
paliativos,
experts
clínicos, bueno,
in palliative
médicos,
care,
farmacólogos, que
clinicians,
ajustaron la evaluación y
doctors,
reforzaron aspectos de
pharmacologists
seguridad
that
especialmente. El
strengthened
resultado fue un
security
conjunto de
aspects mainly.
recomendaciones
And so
prácticas
they
diseñados para la
obtained a
atención
series of
primaria
practical
que
recommendations for
priorizan
primary
un
care
seguro y
that
efectivo uso de
prioritize
medicamentos esenciales para aliviar
safe
síntomas.
use of
Acá ven la
essential
distribución
medicine
de
to
expertos de diferentes
alleviate symptoms.
países con
Here we
diferentes
can
niveles de
see
ingreso
the
y
distribution of
también
experts from
diferentes
different
regiones del
countries
mundo.
with different income levels in
Para hacer
different
su
regions
uso
of the
más
world.
asequible y
To make
accesible y fácil de
their
consultar, desarrollamos una aplicación en línea. Acá
use
pueden ver,
better,
por
we
ejemplo,
created
cómo
an
la
online
recomendación para el uso de morfina en la disnea.
guide.
No
Here,
podemos
for
entrar en unos
example,
detalles.
you can see the use
Y
of
también
morphine for
por
breathlessness.
ejemplo, recomendaciones para
Here we
iniciar
can
para la dosis
see
inicial, intervalos,
recommendations
días de
for
administración,
initial
etcétera.
doses, intervals, ways of
En el código
administration. And in the
acceder a esta
code, you
aplicación.
can
Bueno, y
access
finalmente
this
también
app.
algunos comentarios y consideraciones y preocupaciones importantes para su uso.
And then we also have
Cuando lean
some
van a ver que no todos los expertos están de
considerations
acuerdo.
regarding
Eso
use,
fue muy
and
interesante,
not all
pero
the experts
pudimos leer
agree.
diferentes
That's
opiniones de
interesting,
acuerdo
but
a las a las regiones.
wrote the different opinions according to the region.
Como la doctora Dele decía, el costo es muy
As the
bajo y
doctor
el
was
impacto
saying, the
es muy
cost is
alto.
very low and the
Es
impact is
entonces
very
es
high.
posible de implementar
And so it
estos
is
paquetes
possible
especiales
to
con
implement
mejor
these
si se puede
essential
con el paquete
packages,
expandido.
and it's better if we do it with the
Para
expanded
finalizar, quiero
package.
compartir una hoja de
So
ruta
to
práctica para
finish, I
avanzar en
want
la
to
región.
share a roadmap
Primero, es
for the
fundamental
region.
reconocer que los cuidados
It is
paliativos para
fundamental to
adultos y niños
recognize
son
that
una parte del
palliative
Plan Nacional de
care
Beneficios en el
are
marco de la
part of
cobertura
the
universal en
National
salud.
UHC
No hay
benefit plan.
cobertura nacional de
There
salud
is
sin
no
cuidados
national
paliativos.
health coverage
Los
without
países
palliative care.
pueden adoptar
The countries can adopt the
como el
essential
estándar
package
mínimo
as a
nacional,
minimum national standard,
especialmente en el nivel de atención
especially at the
primaria,
primary
donde se
care
encuentran la
level,
mayoría de los
where we
pacientes.
have most of the
Y es
patients.
clave alinear las
And
listas
it is
nacionales de
key
medicamentos
to
esenciales y las
align national
regulaciones de
essential medicine
opioides
lists,
y también los
opioid
procesos de
regulations,
distribución con los
and
componentes del
also
paquete,
procurement
porque si no
processes with a
ajustamos la
package.
normativa,
Because if we
el
don't
paquete no puede
adjust
implementarse
regulation, the
plenamente.
package cannot be fully implemented.
También se necesita invertir en
We also
formación
need to
basada en la
invest
atención
in
primaria y equipos
primary care-based
multidisciplinarios,
training and
asegurando que quienes
multidisciplinary teams to
ejercen las
deliver
personas tengan las competencias
adequate care
necesarias para
provision
ofrecer cuidados
based
paliativos.
on the
Y
package.
finalmente, es
And
importante
finally, it is
monitorear la
important to
implementación
monitor
con indicadores simple,
implementation with
como
simple
disponibilidad de
indicators,
medicamentos,
availability
existencia
of
de equipos
medicines, trained
capacitados, número de
teams,
pacientes
number of
atendidos,
patients
que nos
reached,
permita
including
saber si
children,
realmente estamos
that will
llegando
allow
a
us
quienes
to
lo
know if
necesitan.
we are getting
Bueno,
to
para
those
cerrar,
needed the
algunos
most.
mensajes,
And to
como
finish,
mostró
some
Afsan Badelia, el
messages.
sufrimiento asociado a la salud está aumentando y
Um,
se distribuye en forma muy desigual entre los países
Suffering
y
related to
dentro de
health
los
is
países.
increasing,
El
and
paquete
it's unequally
esencial ofrece una
distributed
respuesta
inside
mínima
countries and between the
orientada a la
countries.
atención
And
primaria
so
hacia
this
este
package
sufrimiento. El
offers
paquete expandido permite
minimum
adaptar
response, and the
progresivamente
expanded
la
package
capacidad
allows to
según los
increase the
recursos de
capacity
cada sistema de
according to
salud.
the resources of
La
each health system.
disponibilidad no es lo mismo que el uso seguro.
Availability
No
is not
basta
the
con tener los
same thing
medicamentos
as
esenciales,
insurance.
hay
It's
que
not enough
saber
to
también
have
usarlos correctamente,
essential
especialmente en
medicine. You
atención
also need
primaria.
to
Por
know
eso
how to use
desarrollamos este
it
manual de
right,
uso de
especially in
medicamentos
primary care. And
esenciales
this is why
y
we
por último,
developed this
la
manual
colaboración
with
global
essential
es
medicine. And
indispensable
finally,
para
global
generar
collaboration
evidencia,
is
para validar
essential to
estas nuevas
generate
tendencias
evidence and to
y para
validate
llevar los
these
cuidados
tools
paliativos a escala.
and take
Todo este
these
trabajo solo es posible
this
gracias a
palliative
la
care
cooperación entre
to
regiones,
scale.
entre
This is
instituciones
only
y
possible
profesionales
thanks to a
como
cooperation
ustedes
between
que nos
regions,
colaboran, que nos
institutions,
ayudemos y
and
nos
thanks to
unamos
professionals like you
para
that
mejorar esta situación que
help
nos
everyone
afecta a todos,
get
¿no? Los
together
objetivos
to
para el
solve a
centro de todos.
situation that affects
Muchas
everyone. Thank you
gracias.
very much.
Obrigada. Thank you.
Muchísimas gracias, doctora Tania Pastrana.
Thank you very much, Dr. Tania Pastrana. Thank you for describing this consensus process with many experts and leaders with palliative care. And some of you are connected here with us. You have participated in this consensus project for Latin America and to show the essential package and the expanded package for the region. And what is interesting is the part in medicine, oral morphine, injectable morphine, which is key for pain management, as well as the gaps that exist in the region. So thank you so much for this work, and thank you so much for showing it. And we are still in the implementation of these packages because, as you say, without palliative care, there is no universal health coverage.
And
So
I want
thank
to
you
thank
very much.
all of you, the almost 500 participants who are connected to our webinar on palliative care from throughout Latin America and the Caribbean and really throughout the world. I want to recognize our colleagues from Sri Lanka, Zambia, Pakistan, Armenia, South America. It's a great pleasure to have you here with us as we at PAHO are working with the International Association for Hospice and Palliative Care to promote the implementation of these essential and expanded packages for adults and children for palliative care. Y seguimos en nuestra programa hoy
And now we're going to continue with our program, and we're going to focus on human resources that, as we saw, is a key component of the essential and expanded package for palliative care. And one of the activities that we're carrying out at PAHO and in the Latin American Association for Palliative Care is the continuous training of human resources. And we have continuous education opportunities in the region. And to talk about these opportunities, about the different experiences that we have promoted in the region to form human resources and palliative care, we have our colleague, our associate, Dr. Mark Soldenberg, that works in the General Massachusetts Hospital. He's going to talk about the strengthening of palliative care research in Latin America and the Caribbean.
Perfecto, muchísimas gracias, Silvana.
Thank you very much, Silvana. Hello, everyone, and sorry for that. I am very happy to be here today, this morning, this evening, I don't know where you are in the world, to talk more about palliative care and how we can work in the network to continue providing access to everyone who needs it. So this is the first thing that I want to say. You heard Dr. Tanya, and you also heard Absent. We are really at a very exciting moment regarding palliative care and the development of palliative care. 10 years ago, 20 years ago, we didn't have research and the data to understand what is palliative care and how we can grow. But this is really changing very fast, and now we're in a new times. So welcome to you all. Welcome to everyone that's inside, and for the people that are still outside, please come with us. And so this is very exciting. The first thing is that development of palliative care in Latin America is very heterogeneous. It means that there are areas, cities that have access and the quality is very good. And so we have good examples to learn. And at the same time, we know that there are huge gaps, especially in rural areas, but there are also countries that need to create more access for most of the patients. And so it is important to note where we're at. So there are gaps, but inside Latin America, but also in other areas of the world, regions of the world, we know that there are ways to do it. We have examples, like, for example, in Kampala in Uganda, cancer in Chile, or in Costa Rica. We have examples that show that in 5 or 10 years, a ministry that works on this with national leaders can really change this and close the gaps in several years. And so we know that it is possible and it is profitable. But the question is, how can we do it? And so to explain this again and to be very clear, I always say that we're in a new phase of palliative care development. Before, it was a time to build. How can we measure suffering? What is a complete team? How can we integrate this at a city level or a national level? It's very important, and it's great that we did that research, but I think that now it's enough. We can stop, and now I believe that it is not the time to continue with research. It's time to go, to close, to work in networks, to work together, and to make access grow. And so I'm going to say this very quickly in 10 or 11 minutes. There are three strategies that, according to my experience, are very important. The first one is that we have to collaborate instead of doubling the work. Then we have to focus on access, absolute access, and also quality, because we only have because if we only focus on access and not quality, that can be a problem. And then the last part is that the solution is our young leaders. And so we need to pay more attention to them to have a brighter future for everyone. So let's talk about the first part. I am absolutely sure that part of the solution is collaboration, and we need to use networks to do this. There is too much work to double each thing. Each institution, each school does not need to have a palliative care curriculum. Do it by themselves, because we will repeat and repeat and repeat in each country, and this means starting from scratch. We can be faster and more effective if we collaborate regionally, but also internationally, to see what is working well, to see who uses this essential package, and to integrate this and then share it with everyone, because it's not my way of doing it. It's how can we share to close a gap. That's one thing. And some very important details here. The resolutions for Latin America are not in the United States. Sorry, solutions for Latin America in the United States. the most innovative examples, the most interesting examples, and the most interested examples, the most integrated examples in culture is not in Latin America. They're in Uruguay, in Colombia, in Chile. And so when we are looking for solutions, we talk about international solutions, but we cannot look at the north. The south has to look at the south. So I think that this is something that's very clear that I would like to. How did I learn this? In the past 5 years, along with PAHO and WHO, we're trying to have different versions of networks to try to foster that collaboration. So I'm going to I'm going to summarize 5 years of history in 5 minutes. So we started during the pandemic, and when I talked with we started doing an echo. We started with an echo program. I think that most of you know this. And so we started one in English in the Caribbean and one in Spanish in Latin America. And the program in the Caribbean is still going on. And in Latin America, we change it sometimes because the size and the context is a little bit different. And then we try to, and the first session was Latin America. We had like 200 people, and we couldn't manage 200 people in an echo. And so next year, we tried with a more advanced group and a more basic group. This worked, but we also realized that we needed to have young leaders and how to implement palliative care. It was a question for clinicians. And so we did a third version, and this was like a session, an in-presence workshop in the ATP Congress. And then we had a virtual program 1 year after. And it was great, but and and we learned a lot. After that, we started doing integration networks along with WHO, and we started in the Caribbean in 2024, and that was the first meeting for the WHO work group. And after that, we started with another one that started like 1 year ago with a collaboration network that was directly connected. And this made the collaboration grow, and this network is still going on. And the most recent thing, we also have the Caribbean Echo, as I told you before, but now we also have a network with AAHPM in the United States. And the last thing that we're launching is new campus program that works with different countries to integrate palliative care. And we're going to start in 2026, like in March, with 12 countries in the world. So 2 countries from each region. And so we are very excited regarding the new network versions that we're building. And so what did we learn? The energy, the generosity, and the satisfaction in the program has been very positive. It was an honor, and I love the opportunity to do that and continue learning. Part is very important, and we didn't start with our ideas and our research questions. We started with needs Latin American leaders. And so we started with the needs of people that are doing the daily work, that are taking care of their patients. And I think that we need to learn from the start with that. And there is no single way to do a network. We need many networks and to connect, build relations, provide mentorship opportunities. This is better for everyone. So that was point one. We have to collaborate. And two very quick points, and then I will give the floor to the next speaker. The other thing that I saw with other program colleagues is that we need to think in access, but at the same time, we need to integrate quality metrics to
ensure,
make sure that we're having an impact on patients. And if we don't look at that, we can have minimum effect or we can even damage. And so a very clear example, this is Colombia. And I'm going to give you two examples. There was one patient related to my wife. She went to a hospital in Bogota and she received palliative care and palliative care services. A doctor came and asked, "Where is your pain? How much morphine do you need?" He created he gave her medicine and no more follow-up. And that was the palliative care service. And there are other services in Bogota. There was another patient. It was not the same patient. In Manizales that had 50 something with a new metastatic cancer, and she received she was researched for 1 hour by a doctor, then a nurse, then a psychologist to talk about her suffering, her existential suffering. And this is, and after that, she went to a team that was connected to visit her weekly to help her with her care. And she also received palliative care. Are these the same? Absolutely not. I'm not saying that Manizales does this with every patient, but we need to have a vision that includes quality. And then we need to support we need to support the energy and the vision of the young people that want to work in our field. This is why I'm very happy that they are here and we need to support them. And our original leaders, I don't mean to say our old leaders, but our original leaders worked on something that was different 20 years ago. They had to shout to leaders, they had to shout to WHO that palliative care is essential. And thanks to them, we're here now. And I think that the situation is different now. We don't need to scream, to shout. Most people know at ministerial level that this is important. And so they're not wondering what is palliative care, but how can I implement this? How can I integrate this? And so the other day in a WHO meeting, a person said that what brought us here is not what will take us to the place where we need to go. We need to think about new ways. It is not the time to shout and have the same investigations or research as before. Now we need to think that we need to mentor our young people so that we can continue growing together. And a last thing, for some that are listening, we have a collaboration with Harvard and a Catholic University in Chile. These are programs for young leaders that want to grow in their communication and leadership and integration skills. So here you have the QR code for that. It's October and April. And so if you want to enter, it's for next year in October. And we're very happy to welcome you. And if you want to enter, it's a great opportunity to grow in palliative care and close gaps. And if you are something that's new in this and you just want to learn a little bit more, here we have a great example. We have work between PAHO and some collaborators that we did 5 or 6 years ago. Here we have a fully free course, and more than 300,000 people have done this. That's another option for you. And so I believe that I have one more minute. Thank you so much for the opportunity. Excellent. Thank you very much, Dr. Marks.
General Hospital, por la colaboración, por estos tantos años colaborando para fomentar la educación continua, esta colaboración con jóvenes líderes en América Latina y el Caribe y los recursos humanos, desarrollando la capacidad de los recursos humanos en América Latina y el Caribe. Muchas gracias. Y también este webinar es otro ejemplo y tipo de crear la comunidad de práctica, ¿no? En
This
cuidados
webinar is
paliativos.
also an example on how we create a practice community in palliative care. And from PAHO, we're going to continue working closely with IHPC and the Association of Latin American for Palliative Care to continue having these kinds of webinars, to continue collaborating, to continue sharing experiences and developing this network for palliative care. So thank you very much for your participation today. And we're going to continue in 2026 with other webinars. But we're not going to close yet. We have more in our program today. And now we want to talk about the importance of palliative care in pediatric populations because we know that the needs of children and adolescents that have cancer or other non-communicable diseases require specialized care, and the gaps for those populations are even greater than for adult populations. And so since at PAHO, we're working with the global initiative on child cancer and our partners in St. Jude Hospital, and this has a palliative care component. And so to present PAHO's work to strengthen palliative care in child cancer, I invite Liliana Vasquez, that is our oncological pediatrician here at PAHO.
Silvana, y muchas gracias a todos los presentadores de este webinar. Realmente para
Thank you,
nosotros es
Silvana,
gran
and
placer
to
poder
all
tener
the
esta colaboración
presenters in this webinar.
conjunta y poder
I'm
tener
glad to
oportunidad de llegar
collaborate
a tantos
together
colegas
with
que
you
están
and have the
trabajando
opportunity
en
of
tema de cuidados
reaching so
paliativos.
many colleagues who are working
Realmente,
on palliative care.
escuchando muchos de los comentarios de
Listening
los
to many
grandes expertos que
comments
están el día de
from
hoy en
the
este
great
webinar, es
experts
cierto que el acceso a los
in
cuidados
this
paliativos
webinar, it's true that access to palliative
es un tema
care
importante, sin duda es un tema
is important,
prioritario. En el
undoubtedly
caso de
a
los niños,
priority.
con
In the
mucho más
case
razón,
of children,
porque
even
sabemos
more so,
que el
because we
acceso a
know
los cuidados
that
paliativos
access
pediátricos
to
todavía no es
pediatric
suficiente.
palliative care is still
Históricamente,
not
los
enough.
niños, niñas y adolescentes
Historically,
siguen
both
teniendo
girls and
brechas muy
adolescents
importantes en tener
have
cuidado
very
paliativo
important
en
gaps in
relación a los
terms of
adultos.
palliative
El
care
uso de
in connection
medicamentos
to
para el
adults.
dolor
The
en los
use of
niños
medicine
sigue
for
estando por
pain
detrás del uso de
among
los
children
medicamentos
is
para
behind
los adultos, y los
medicine for
recursos que se
adults,
tiene,
and the
incluyendo los paquetes,
resources
muchas
we
veces
have,
no
including
cubren las
packages,
necesidades
do
que
not
se
cover
necesitan
the
para
needs
el cuidado pediátrico. Entonces,
for
esto
pediatric care.
en general es un problema
So generally
importante.
speaking, there's an
Desde
important
OPS
problem. At
tenemos
PAHO,
un mandato
we
muy
have
importante, lo
a very
mencionó
important
también Silvana,
mandate,
desde la
as
Iniciativa
was
Mundial
mentioned by
del Cáncer
Silvana,
Infantil. Uno de
the
los pilares,
child
sobre todo más
cancer
importante, que tiene que ver con los centros de excelencia, con la cobertura universal, busca integrar los cuidados paliativos
universal
pediátricos en
coverage
los
tries to
paquetes de atención.
integrate
Busca
palliative
acercar
care in
realmente estos recursos que no tienen que ser
care
solamente para,
packages.
por supuesto,
We
el personal
approach
médico, sino
these
para el personal no médico,
resources
para
not
todo el
only
personal de
for the
enfermería,
medical personnel, but
psicología,
also non-medical
psicosocial,
personnel
técnico,
like
y poder
nurses,
tener realmente
psychologists,
un abordaje mucho más
technicians at
integral
large,
de
so that they
comunicación
can have a
previa-agresivo desde el
more
diagnóstico.
comprehensive
Durante mucho tiempo
approach, even
se
from
pensaba que solamente
diagnosis.
los enfermos o los
For a long
pacientes en
time,
etapa
we
terminal
thought that
debían
only
tener un acceso
terminal
digno a
patients
estos
should have
cuidados, y ahora sabemos
dignified access to
y
this
promovemos, por
care, but
supuesto,
now we
de que
know
esto
and
no sea así,
promote
que haya
that this should
un
not be the
acercamiento
case,
mucho
that there
mayor
should
desde el
be a
diagnóstico de un
closer
cáncer, por ejemplo, de un
approach
niño,
in
niña y
the case
adolescente.
of a cancer
Existen ya documentos
diagnosis,
muy importantes desde los
diagnostic
grupos de trabajo de la Organización
in
Mundial de la Salud,
children
desde los
or
trabajos que se
adolescents.
hacen
There
a
are
nivel
works
global
done
internacional,
at
y para nosotros
WHO,
desde la OPS
PAHO,
con, digamos,
globally,
el Cure
regionally,
Américas,
and
curar a todas las
here
Américas
at
con
PAHO
cáncer
with
y con
our
enfermedades
Cure
catastróficas a través del
All
marco de
Americas
trabajo
for cancer and
la Iniciativa
catastrophic
Mundial contra el Cáncer Infantil.
diseases in
Pero
the
sabemos que sin
World
duda
or Global Initiative Against
el diagnóstico
Child
de
Cancer.
cáncer en un niño, niña y
Undoubtedly,
adolescente es un
if
porcentaje menor en
a
relación a muchos
child
de
or
los otros
adolescent is
diagnósticos
diagnosed
que ameritan
um,
un cuidado
for cancer, This will require palliative care, quality of life. We also have congenital diseases, autoimmune, neurologic, whole gamut of conditions that have to be addressed with a palliative care approach. And that's what we want. We want that to be accessible for all. Dr. Pastrana said so. Palliative care is a task of all of us. And we have been in debt for many years, particularly with children. So it's necessary to integrate pediatric palliative care as from diagnosis, also in public policies and public health interventions at the ministries of health or wherever we are from our communities. We need to improve communication, improve symptom control at an early stage, have more adhesion to treatment. And we know that palliative care is very cost effective. It's no luxury. It's these interventions did not reach the community at large because it was behind many priorities. But now we know that it saves resources, hospitalization days, suffering among children, morbidity. We know that a sequel can last for several years and even decades. So a child and the entire family, mom, dad, all the community, siblings are affected. So we need a comprehensive approach for these patients. And this is the Cure All framework. This is the WHO Global Initiative for Childhood Cancer. The idea is to optimize limited resources. Early detection, diagnosis, treatment, and palliative care are important pillars in this, and also survival care and oncologic treatment for children with cancer related to palliative care. This is a global initiative. This is the global initiative on child cancer. It's like a dream. We want to improve survival no matter where they live, where they have been born. We want to reach at least 60% to 2030. Very importantly, the mandate includes decreasing suffering and improving their quality of life through a work package that is aligned with health systems to improve excellence centers, universal coverage, treatment regimes, evaluation and monitoring on three pillars: advocacy, financing, and governance. And this is for all the Americas. This isn't to cure all Americas. I'll leave you our email and also the PAHO email so you can contact us. We're totally open to contacting you. These are more than 200 professionals in the Americas who already participate in working groups, particularly on palliative care. We have lots of colleagues from many countries. We have been able to get some funds also, and we'd like you to help to disseminate and implement this in your daily professional activities. And of course, we are improving. We can always improve. There has been a co-design evaluation of situational diagnosis, need assessment, development of metrics and dissemination since 2023. It has been important to develop a situational diagnosis on PC. Beyond cancer, what's a photograph? How many, or some snapshots, how many plans we have? And this is based on the bright work of Tanya, work, EPSA, and all the colleagues and global associations on palliative care who have published atlases, manuals, and technical documents that involve children too. And this is accessible through the PAHO website, and you have the QR there. This regional panorama includes, or outlook includes, pediatric palliative care in several countries in the region, and some inequalities we have in terms of access, cancer and health policies, also educational materials for parents and caregivers. This can impact the clinical practice of our countries. These are infographies or infographics on pediatric palliative care. This has been done together with the St. Jude Children Hospital in their collaboration with WHO and PAHO. They have designed graphs on and some work frameworks that they share and are available in English, Spanish, Portuguese, and French. Mark also commented about the virtual course of palliative care on pediatric cancer. It is totally available in the Cure All web, and you can have access to it through the PAHO website. More than 70,000 participants in this course, not only from the region, but also outside. We're very proud because we know that we can have resources. We don't need to reinvent the wheel. We can adapt many of these opportunities, tools, and documents for all. We also have audiovisual material for the community, parents, caregivers, or for just anyone who would like to know more about palliative care. Finally, this is a snapshot of our toolkit. All these resources are included in our toolkit, and they are available for families, communities, as videos, infographics, also for health professionals, not necessarily specialists, also people in primary care. We all have a role on palliative care for boys, girls, adolescents with cancer or any catastrophic disease that requires palliative care, and also for public health specialists with much more specific information based on what we are going through in the region. So visit the website, check the documents, and share them with your colleagues and the community. Finally, this is my email, the Cure All email at PAHO. If you'd like to be included in this great initiative and the work we are doing together. Thank you very much. Excellent work. Thank you very much, Dr. Liliana Vasquez, for describing PAHO's work together with St. Jude's and some of the colleagues who are participating with us in the International Initiative on Child Cancer that has a strong component for palliative care. This is the end of our agenda, but we have a few minutes before we finish this webinar to answer your questions. You're asking several questions through the chat and the Q&A section. So I'm going to invite our panelists, Liliana, Tanya, Afsan, and Mark, to open their cameras and have some sort of exchange according to the questions we received before we finish our webinar, and also to promote discussion in this network we are expanding. We have Curol, we have the ECOS and the Latin American Association, and also IADHC. First question then.
Probably responded to, so I don't see it in the Q&A anymore, but there was a question, Afsan, when you were presenting some of the data, especially on the needs for palliative care globally and for the region of Latin America and the Caribbean, if there was data disaggregation by stratifiers such as people living with disabilities or different income levels, or if you could just reflect a little bit more on the data on needs for people with palliative care. And then after Afsan responds, I'll invite the others. Liliana, if you want to talk a little bit about needs for children with cancer in terms of what we know in terms of the data, Mark and Tanya as well. Afsan.
Thank you, Silvana. Yes, so I should have mentioned that the assessment or analysis to measure the burden of SHS is based on GBD mortality and prevalence data. And so we have to be, we're limited by what is available globally for comparison. But the work that we have done with the updated estimates does disaggregate by sex, 4 different age groups and country income level, as well as geographic regions. In terms of disability, the focus is more on symptoms, right? So sequelae related to the symptoms related to SHS. But I think you pose an important question around in terms of how do we measure disability due to suffering. And so what I didn't mention is a proposed next step as part of the Lancet Commission's work around development of suffering-adjusted life years. And this is a tool to measure suffering avertative interventions and to complement existing metrics like DALYs and QALYs, which do not effectively incorporate, some of these sequelae. For example, pain, there is a large focus on back pain, but we're not really thinking about it comprehensively. So this is a part of a long-term agenda, and I think we need recognition and investment in development of these type of metrics and available data, quality data at country and then regional, global levels to do further analysis. One thing I will note, we did some previous work on looking at human development, right, indicators. And so I think there's a lot more that can be done to further the analysis. But thank you for that question. And I provided some links to both the updated publication as well as the methodology paper that details, including the multipliers we used around, so with the mortality and prevalence data based on expert review, what is the experience of the patient, right? And how many days of suffering might they experience? But there's still a lot of limitations in terms of data, and we need to strengthen this.
Thank you. Liliana, do you want to reflect on data?
Sí, no, es un tema muy importante. En pediatría
It's a
puntualmente
very
existen
important topic.
análisis ya
I
bien
would
sobre primero las necesidades de los cuidados
first
paliativos
of
en
all
los
talk
niños
about the need of
y
palliative care in
adolescentes,
children
sabiendo
and
que
adolescents,
solo un par de cifras,
knowing that
más o menos son
use a
ya
couple
son
of
casi 4
figures.
millones de niños
It's
en el
almost
mundo
4
que se
million
estima que
children
van a
in
requerir
the
algún
world
tipo
that
de
are
cuidado
going to
paliativo.
need some
Y de
type
ellos
of
más o menos
palliative
son
care.
250,000
And
se estima que
250,000
están en América Latina y el Caribe, ¿no?
are in Latin
Y de
America
ese
and the
grupo,
Caribbean. And out of
un
that group,
grupo va a tener cáncer. Por supuesto, la
the
mayoría
group is going to have,
más patologías
a large part is
que
going
ya
to
sean
have cancer,
neurológicas y otras, más prevalentes, pero
neurological
no menos de
diseases and
50,000
other
niños
diseases.
hoy
Well, not less than
en la
50,000
región
children
requieren de
today
cuidados
in the
paliativos. De
region
ellos
need
hay una
palliative
gran
care. And there's a
en
great
cuanto a lo que
gap
es el
in
acceso
terms of
al cuidado
access
paliativo
and
en
perspective
términos
to
de
palliative
atención,
care, in
de
terms of
provisión
care, in
de
terms of
tratamientos específicos, de
specific
medicamentos.
treatments,
Y
medicine.
otro tema que también
And
relacionado
another topic that is related
mucho que ver con
and that
formación de
has a lot to
recursos
do
humanos.
with,
Que es gravitante
I'm sorry,
que
but
los
the audio is not very good. And it's
especializados
important
puedan
for the
tener un
professionals to
entrenamiento en
get
cuidados
specialized
paliativos.
or have
Solamente
training in
la gran
palliative
mayoría
care.
de los países
In most
en la
countries
región
in the
tienen
region have
equipo de cuidado paliativo
palliative
pediátrico
care
o menos por
teams
millón de habitantes. Entonces,
for
estos
less
son
than 1
datos
million
que realmente nos
or
llaman a la
half a million
reflexión para
inhabitants.
poder
And this
mejorar ese
calls our
aspecto de lo que
attention
son
to be
políticas
able to
públicas,
improve public
el
policy,
establecimiento de guías a nivel
establishing
de los
guide
países para poder insertar el cuidado paliativo pediátrico dentro de, por supuesto, todo
to
la
include
atención
pediatric
integral del
palliative
paciente
care in the
pediátrico, pero yo creo que es muy
in
importante
pediatric
conocer
care
estos
in
datos
general.
para poder saber
And it's
hacia
very important to know this data, to know
nos dirigimos
where we're headed to, but emphasizing on people. And we have to work, and working on palliative care is really going to mark the difference abroad. We have to take advantage of the packages that are available for children as well as for adults. Thank you very much, Liliana. Do you have more thoughts on the disaggregated
Bueno,
data?
sí, por un lado, estos datos
On
incluyen
one side,
muchas
this
condiciones
data includes
bueno,
many conditions.
una amplia cantidad de condiciones, ¿no?
It's a large
También
amount of
muchas de estas
conditions.
condiciones, como la de
And
niños, por
very
ejemplo,
often, these
viven
conditions
con, ¿cómo
are
se llama?
those of
Disabilities,
children that live with a
están incluidos también
disability.
allí, ¿no? Pero
Sometimes they
yo
are
quería
included
decir,
there too.
Liliana, no
But I
solamente
wanted to say something,
necesitamos
Liliana. We
profesionales y
need
necesitamos que los cuidados
professionals,
paliativos
of
sean
course,
reconocidos
and
como
we
una
need for
disciplina,
palliative
pero
care to
además de
be
eso
recognized as a
necesitamos
discipline.
en el
But we
primer
also
nivel de
need,
atención. No
in
es
the
posible
first level of
ofrecer cuidados
care,
paliativos a
it
los
is not
4 millones de
possible to
personas, 4,5
offer palliative
millones de
care
personas que
to
tenemos en la región
the
solamente
4.5
con
million
especialistas
people that we
que
have in the
además
region,
requieren
only with specialists
una larga
that
carrera, ¿no? 7 años
and it also
estudiar,
requires a very long career,
especialistas con
like
Mark.
7 years,
Necesitamos
according to an article that we wrote with
capacitar a los
Mark.
profesionales de la
We
salud,
need
no
to
solamente
train
médicos, pero también otros profesionales de
health
la salud
professionals, not only
para,
doctors, but also other health
para los cuidados
professionals
paliativos en atención primaria,
for
especialmente
palliative care
identificación de
in
necesidades
primary healthcare
todo lo que
systems,
hacemos en
especially
atención
in terms
primaria.
of
También, por supuesto, no
need
es solo, ¿no?
identification,
También en cooperación con los especialistas, que
and
ya
also
no
in
solamente,
cooperation with
no solamente
specialists.
se trata de
So
camas
I
y de especialistas, se
wanted to
trata
say it's not only
de la
about beds and
comunidad, ¿no?
specialists, it's about the
De la comunidad también
community
que
in
sea
general,
contratada
the community
en
that
este
must
manejo.
be trained in this management.
Mark, do you want to reflect a little? I know you guys do a lot of research at Mass General Hospital on this.
Yeah, y yo sé que no tenemos tanto tiempo. Y específicamente por los datos, se acuerda completamente que
So
Liliana y Axel
specifically regarding the
diciendo.
data, I
Y
agree with
yo
my
creo que
colleagues,
una
and I
otra
believe
cosa que
that
ahorita estamos pensando
another
en
thing that we are
como
thinking
grupo
about
de
now in
investigaciones es
our
que
research group
creo que
is
una
that
cosa que
I think
necesitamos
that
es
one thing
más
that we need
información
is
directa
more
sobre los
information and more
proyectos
data
pequeños de
on these
integración.
small
Yo estoy
projects
seguro
that
hay
have to do with
hartos
integration.
proyectos y
I'm
programas,
sure there are
nuevos
many
servicios
projects
domiciliarios
and
en lugares rurales en la
many
ciudad,
projects
nuevas
regarding
ideas que uno puede integrar
rural spaces,
con
cities,
oncología que hay
and
en
how we can
Latinoamérica,
integrate
pero
this
no
with
hay
oncology.
suficiente recursos, infraestructura para
But
hacer la
there's not
investigación y
sufficient
publicar,
resources
entonces nadie
to do
sabe
research and
de las
publish, so
innovaciones
no
que están
one knows
pasando.
on
Entonces
the
nosotros estamos pensando
innovation
cómo
that is
podemos
taking
dar
place. So we
eso,
are
apoyo,
thinking, how
recursos,
can we
como
create
incentives
courses
para
as
ayudar personas
incentives
que están
to
haciendo un
help
trabajo
people that
vicioso
are
muy bonito
doing
que pueda ayudar
very
en
good
otras
work
partes de la región
that can help
para
in other
tener
parts of the regions,
suficiente como ayuda para publicar
to have
y
enough
escribir
help
que
or
pueda
support to
compartir.
publish
Entonces yo creo
and
que es una de
share.
las
I
áreas de
think that this
investigación que
is
nosotros
one of
estamos
the
intentando
research
evaluar.
areas in which we're trying
Como
to focus
evaluación
on,
del impacto de las intervenciones, cómo
like
integrar
assess
los
the
cuidados
impact of
paliativos en la atención
interventions,
primaria de salud, por
how to
ejemplo.
integrate palliative
Exacto.
care
Que
in
está pasando, pero no
primary
estamos
health care.
midiendo para
Yes, because this is
entender
happening,
y
but we don't have
Excelente.
resources to
Bueno,
know about this
antes de
and share it.
terminar, quiero
So
hacer
before
una
we
nueva
finish,
ronda de
I would like to
preguntas y
have a
respuestas
new
sobre
round of
algo que
questions
yo
and
vi en el
answers
Q&A,
regarding
que
a
es
question that I
súper
saw in the
relevante
Q&A
para
that
las
is
discusiones
really
sociales
relevant
en este
and
momento,
due to
por
the
lo menos en
social discussions
Canadá.
that we're having now, at least in
Es
Canada,
sobre
my
medical
country.
assisted
This is
dying,
about medical assisted dying,
porque yo sé que se está
because I
tomando
know
estas
that
discusiones en muchos países en
these
América Latina, en España, en otros
discussions are
países.
happening in
Así
Latin
que
America and in Spain
with
and other
medical assisted
countries.
dying, there's going to be need for greater human resources, equipment, supplies, those essential packages for palliative care, but then also the legal frameworks, the social supports, the, sort of the associated services. So I just wondered if from IHPC, from Mass General, from Purdue University, Liliana, if you want to reflect, I don't know, from GICC, if there are some perspectives or discussions around medically assisted dying. And that could be another topic we take for the next webinar, but over to you. And before we open up again, Liliana de Lima, I see you're connected. Thank you. It's great to see you. And thank you for joining Liliana de Lima. She doesn't need any introduction. She knows her, executive director of IHPC, an outstanding leader for many, many years in palliative care globally. Liliana, welcome.
Gracias, Silvana. Y disculpen, estoy con catarro, así que
Thank you
bueno,
very much, Silvana. And I'm sorry because I have a sore throat and my
I'm
voice
hearing the
is kind of
translation.
weird.
So I was just on the issue of assisted dying. The IHPC has an official position because we're an international organization. We have to be respectful of how nations decide their own legislation and regulations. However, our position is that no patient should have access to assisted dying before having had access to palliative care. We think that individuals who are probably requesting assisted dying, it's because the suffering is unbearable. They have physical, existential, spiritual, emotional suffering, and they are requesting, assisted dying to alleviate that suffering. So that's the official position statement of the IHPC. Just wanted to make sure that it's clear out there. And apologies again for my voice.
And sorry for your voice, and thank you for joining us, even though you're not feeling well.
And thank you. Thank you for doing this, Silvana, and everybody else who presented today. You've been amazing. Thank you.
It's been a great pleasure to have you, Liliana, to have the entire network of IHPC, to have all of our speakers, Afsana, Tanya, Liliana, Mark, and all of you. We had almost 400 or 500 people connected today from not only Latin America and the Caribbean, but from around the world. And it shows the commitment, the need for sharing information. We've got links in the chat for all the manuals that were presented today. And please stay in touch, visit all of our websites, PAHO, Mass General Hospital, IHPC, the Latin America Caribbean Palliative Care Association. That's where you'll find a lot of the resources and websites. And please stay connected to the PAHO listserv, which is where we'll be announcing all of our webinar series for palliative care, for childhood cancer, for cancer in general, for NCDs. We have a lot of webinars. And of course, we're going to continue to collaborate with IHPC next year to expand this work and the network that we're creating to promote the adoption of the essential and expanded package of services for palliative care. So Liliana, if you have a little bit of energy to say some perhaps closing remarks for us all, we would love to hear from you and close us out.
Thank you, Silvana, and thanks everybody. I just want to thank everybody for being and attending the seminar today, and I want to also thank the panelists for great presentations. You were able to pack a lot of information in just a few minutes each. I really enjoyed it. It's been a blessing and an honor to be able to participate and also work with all of you in this effort, in this project. And I look forward to working with you, Silvana, and everybody else at PAHO and all the team members in implementing the packages. We're here to help and support your efforts, and more than glad to be able and participate in this network that you're facilitating. Thank you so much, Silvana, for what you're doing for the Americas.
Excellent. Thank you, Liliana. Thank you to all our presenters and participants. Thank you. Have a great day, and we'll be in touch. Bye.